Kris, before I even welcome our listeners, I want to put a situation to you. Suppose I am admitted to hospital tomorrow morning at 8 o'clock. I have never met the nurse who takes my blood. I have never met the doctor who will decide what happens next. I have no idea whether this hospital is any good. And yet, within half an hour, I will let complete strangers put a needle in my arm and make decisions about my body. Why on earth do I do that?
Because maybe you have almost no alternative. And because most of the time it works out well. But Jolien, you have just described the absolute most underestimated concept in all of healthcare. You did not hand over your arm to a protocol, you handed it over to human beings you decided to trust in a matter of seconds. As a healthcare professional, you might know a few things about hospitals, but the average human being makes these crucial decisions on the basis of very limited information. That is remarkable.
Can you actually define trust academically? Or is it one of those words we all use and nobody ever pins down?
It can absolutely be defined. The definition we use in our paper comes directly from the rich literature on trust in physicians. Trust is the baseline expectation of the public that those who serve them will perform their responsibilities in a technically proficient way, that they will take true ownership and not inappropriately defer to others, and above all, that they will make the patient welfare and well-being their absolute highest priority. You trust them completely to provide quality care.
Let me hold you right there, because there are 3 separate promises hidden in that one sentence. 1. You are competent. 2. You take responsibility, you don't pass me on. 3. I come first, before the schedule and before the budget. Is that a fair translation?
That is spot on, exactly. And listen, this is not just some soft feel-good variable. Trust in the workforce is strongly associated with high patient satisfaction, better continuity of care, far more beneficial health behavior, fewer symptoms, higher quality of life, and incredible adherence to treatment. Now, I should be careful with the word associated, as much of that evidence is observational, but the pattern across studies worldwide is remarkably consistent and powerful.
Welcome to Kris Vanhaecht on Quality. I am Jolien Palmaerts, and today we are going to spend 15 minutes inside a house. Not a real one, a conceptual one. The House of Trust, published in F1000 Research by Kris together with Peter Lachman, Charlotte van der Aura, Deborah Sijs, Fien Claessens, Massimiliano Panella, and Dirk de Ridder. My ambition for this episode is simple. By the end of it, you should be able to draw this house on the back of an envelope and explain to a colleague with passion why it matters. Kris, welcome. You are full professor in quality of care at Leuven University in Belgium and work with colleagues around the world to enhance care quality and empower the healthcare workforce.
Thank you so much, Jolien. I love that challenge. If people can draw it, they can truly use it and transform care.
Then let me start with the objection. On behalf of every listener who has sat through one improvement program too many, healthcare is drowning in frameworks, models, pyramids, wheels, triangles. Why on earth another one?
That is a great, honest objection, and we actually wrote it into our paper ourselves. People might say the literature does not need another angle. But let me answer that with 2 energetic observations. First, existing models have helped us enormously. Our whole field stands proudly on the shoulders of giants like Deming, Juran, Feigenbaum, and Crosby, who pioneered improvement methodology. And in 2001, the Institute of Medicine gave us 6 core domains: safe, effective, person-centered, timely, efficient, and equitable. That organized 20 years of work, including my own work at Leuven University.
And what is your second observation?
Alongside those methodologies, we imported heavy control systems, accreditation, certification, regulation, inspection. They raise the floor and force organizations to measure and audit. But I have never ever met a patient discharged from hospital who said, "I felt so wonderfully cared for because they were accredited."
So accreditation alone simply cannot produce trust.
Exactly. It can build conditions, but it cannot build human relationships. That distinction is why our paper exists. Meanwhile, trust has been declining. The pandemic and misinformation eroded it further, and yet studies like Bates and colleagues in 2023 show harm levels in hospitals remain high. As Don Berwick points out, safety and trust must be an unrelenting, passionate focus of leadership every single day.
So we have built vast systems, yet lost crucial human confidence.
That is the core paradox. Add workforce shortages, economic stress, and climate change, and it is clear citizens and healthcare workers need deep, authentic trust in each other more than ever. You simply cannot co-produce real change without trust.
So is the House of Trust just new branding or something deeper?
It is something much deeper. This is what I am most passionate about sharing. The House of Trust is not a replacement. It is a powerful integration. It connects three major streams of work: the expanded Duran trilogy of quality planning, control, improvement, leadership, and culture. Co-production pioneered by Paul Batalden, and our multidimensional definition of quality with Peter Lachman that puts human values right at the heart of the system.
And trust is what those three create together.
Yes, trust is the ultimate outcome. Look at the incredible research by Zenger and Folkman analyzing 87,000 leaders. Trust comes from positive relationships, consistency, and expertise, not superficial charisma, but genuine relationships and competence. That is so inspiring because anyone, from a bedside nurse to a hospital CEO, can practice that every day.
That is such a clear summary. So quality systems raise the floor, but relationships build trust. Now, Kris, let us step right into the house itself. Talk to me about the front office and back office.
I love this concept so much. It comes from service visionary James Tiboul. Every great organization has two dynamic halves: the back office, where systems are designed, and the front office, where care meets human beings. Real healthcare magic happens right at the hinge between the two.
Give us the restaurant analogy because it makes it so vivid.
My brilliant mentor, Walter Sermius, always described it so well. Think of a top restaurant. In the kitchen, the back office, ingredients are prepped, hygiene protocols followed, perfection crafted. As a guest, you don't see it, but you trust it completely. In the dining room, the front office, you feel the warmth, the welcoming presentation, the personal touch. That is where the experience comes alive.
And in a hospital, that kitchen is where we design pathways and protocols.
Precisely. Care pathways, roster design, clinical guidelines, staff training, that is all the kitchen. And it comes alive in the front office during a ward round, a quiet conversation at the bedside, or an empathetic phone call to a family member.
So does the back office matter as much as the front office?
Absolutely. They are vital to each other. If the kitchen fails, no amount of front office charm can save the meal. Suboptimal care is almost never about unkind people. It is about great people working inside poorly designed back office systems. The back office makes excellence possible, and the front office makes it visible.
And that visible encounter is what you call the moment of truth.
Yes, the moment of truth. It is that sacred meeting point between a patient, their family, and a dedicated caregiver. And here is what drives my passion for this work. A suboptimal moment of truth cannot be erased. You can apologize, but a patient told bad news in a noisy hallway will remember that hallway forever.
Patients don't experience protocols. They experience people in moments that stay with them.
What a wonderful way to say it. Exactly. It takes bi-directional communication, dynamic partnership, proper environment, and adapting resources to support both patient and caregiver. It is about total mutual respect.
And you have lived this firsthand as a patient yourself, haven't you?
I have. When I was hospitalized with severe pancreatitis, it completely transformed how I teach and research. What stuck with me most was not just the clinical expertise, which was brilliant, but a physician who truly sat down, looked me in the eye, listened to my fears, and involved me as a true partner. That is the powerful spark between being treated and being genuinely cared for.
That gives me chills, Kris. Now let us walk right through the architecture of the House of Trust. If we are standing right outside looking at this house, where do we begin?
Let us step right into the glowing core of the house. The living room where human connections happen.
And what fuels that living room?
4 energetic core values: dignity and respect, a holistic vision of the person, active partnership and co-production, and deep compassion with kindness. These are the heartbeat of everything we do.
And these values apply to patients and healthcare staff alike?
To everyone, absolutely everyone. How leaders treat staff, how colleagues speak to one another, it all flows together. If respect stops at the break room door, it isn't a core value, it is just marketing.
Some managers might ask, isn't focusing on kindness secondary to clinical safety?
Safety is non-negotiable and foundational, but kindness and clinical excellence work hand in hand. I don't want a friendly nurse who gives the wrong medication, but technical precision without compassion is cold. Our message is clear: strive for outstanding technical excellence and warmth at the exact same time.
Love that! What lies beneath the living room floor?
The solid foundations, well-organized care pathways, smooth scheduling, clear protocols. When the foundation is rock solid, healthcare professionals have the time and headspace to connect deeply with patients.
So structured care pathways are the solid floorboards that keep everything steady.
Yes, grounded in 25 years of research from our clinical pathway network, it seamlessly connects back-office design to front-office delivery on MOM.
And what supports the whole structure underneath?
The support posts, 6 robust posts holding up the building, safety and efficiency as outer corner posts alongside effectiveness, timeliness, inclusive equity and diversity, and ecological sustainability.
Including ecological sustainability in quality care is such an exciting step.
It is essential. The next generation demands that high-quality care protects our planet as well as our patients. True health requires a sustainable world.
Now, tell us about the pillars standing proud in the house.
4 vibrant pillars: transparency, active communication, workforce and patient resilience, and inspiring leadership. Leadership and management are not stuck in back offices. They belong right in the front office, driving culture 24 hours a day, 7 days a week.
How do those pillars elevate daily care?
Transparency builds open trust. Communication connects teams and patients. Leadership models values in action. And resilience energizes and protects our amazing workforce so they can thrive.
And resilience empowers patients and families too.
Absolutely. Patient and family resilience is huge. And for healthcare organizations, taking care of your people is the ultimate strategy to retain talent and stay strong.
And at the very top, crowning the house?
The roof. Person-centered and kin-centered care, supported by every single value, post, and pillar beneath it. It is our inviting vision to the world, co-produced by patients, families, and professionals together.
What a comprehensive structure! Core values, solid foundations, strong posts, dynamic pillars, and a person-centered roof. Now, Kris, how do we actively construct and maintain this house in practice?
With passionate, continuous action. In our paper, we outline the key guiding principles: context, co-design, psychological safety, and continuous learning.
Start with understanding context.
Every hospital and clinic has unique financial, social, and operational realities. We must tailor our vision to real-world context, not abstract theory.
And co-designing with patients and teams?
Always design care with the people who give it and receive it, co-production from day one, and monitor progress intelligently without overburdening caregivers with bureaucracy.
Measure quality to support people, not overload them.
Yes, real excellence comes from within. Inspection sets boundaries, but continuous self-reflection and genuine team learning create true quality.
And psychological safety is what empowers teams to speak up and improve.
Precisely. Psychological safety gives everyone the trust to speak open-heartedly, spot flaws, and innovate together with passion and joy.
For busy healthcare leaders feeling overwhelmed by daily pressure, how can they start?
Start right where you are. You already have a house. Use the house of trust as an inspiring lens. Pick one pillar or pathway, engage your frontline team and patients, and build step by step with energy.
Small, enthusiastic steps created together lead to incredible systemic change. Kris, what are your top takeaways for our listeners today?
First, trust is the ultimate driver of healthcare quality. Second, every moment of truth matters deeply and builds lasting impact. Third, building a house of trust is an exciting shared journey for patients, professionals, and leaders together.
Thank you so much, Kris, for such an energetic and inspiring conversation.
Thank you, Jolien. It was an absolute pleasure.
To all our listeners, keep building trust, keep caring with passion, and see you next time on Kris Vanhaecht on Quality.